Can you tell us a little bit about what exactly is meant by respectful maternity care? What does it look like, feel like? How is it different?
Thank you, Camilla. Maybe I start off by introducing a bit of Kenya to you. Before we go, we just share a little bit on respectful maternity care, or some people call it respectful maternity and neonatal care. So Kenya is a lower middle income country, but some of the challenges that we have is that we have huge inequalities. When you look at the status of women, especially women of childbearing age, we have in some counties, you have around 47 counties in the country. We have some that have as high as 600 per 100,000 life, 600 maternal deaths per 100,000 life births, compared to others that have about 100. So there are huge inequalities. And this is historical. It has been largely about the infrastructural development and also some of the social determinants, such as education, women access to education, poverty levels, and that kind of thing. But zeroing to the issue of respectful maternity care, it is a concept that is so much so about quality of care. It is not just an idea that is out there. It's about how do we deliver quality care to women who are pregnant, are undergoing a delivery, and the period post-delivery. So when we look at RMC, as we abbreviate it, it's about respect to women. It's about them getting dignified care, and it can range from things to do with like humiliation of women as they deliver to other worse conditions such as abuse. And in humiliations, just to bring it home, is where maybe a poor woman goes to deliver in a facility but does not have clothing for the newborn and is ashamed to do so at a health facility because of what the health workers will say about it, and she's not able to afford. So then she keeps away from going to the health facility. Another example is where we have like women who have undergone female genital mutilation, and when she's delivering, you will see other health workers call to the delivery bed, other health workers to come and see, because maybe that community, the health worker doesn't come from that community. And this is demeaning for the woman, it's humiliating, and it infringes on her right to be able to deliver in a facility, feel comfortable about it. So it's a whole range of issues in there. Women who deliver in a facility, they do not have the money or the funds to clear their bills, and they are detained in a facility. So it is a myriad of things, but they can affect the quality of care, because we don't just look at clinical experience of the woman in terms of quality of care, but their own experience in terms of how they're treated throughout their pregnancy journey when they're going for antenatal care, regardless of whether they have good clothing that can fit, with their growing tummies, whether they can afford that, or they're just putting some garment, or during delivery, are they able to afford for the newborn child, even post-delivery, bring the child for immunization. They shy away because of some of these things that they experience with health workers. So in a nutshell, it's a range of things. But the most fundamental things, it's not just about respect and dignity, is that it infringes on the rights of a woman. And even in a country that we have quite a progressive constitution in Kenya, that reproductive health rights are enshrined in our constitution. But still, there is disconnect between what is in law and what is also in guidelines with what is in practice. And maybe as we have more sharing, we'll share more about why some of these issues come about. Thank you.
Yeah, thank you. And that's really, really helpful. What would you say are the key barriers to actually integrating RMC more generally in maternity care?
The first one I would think of is about the provider, the healthcare provider. When you look at healthcare providers in country like Mount Country in Kenya, they are overstretched. You go to the newborn unit, a nurse or a midwife is looking after like 15 to 20 babies. They could be overstretched, and it has a lot on their emotional health. So there's a factor in there about, you know, their mental well-being, because, you know, of that being overstretched by the system. Then secondly is about the infrastructure of that particular facility. Sometimes you find mothers have to share beds when they have gone to deliver, because beds are not available. So it is what the system can provide. So there are also system issues to do with infrastructure, to do with medical supplies, to do with commodities, and such kind of thing. Then the third thing is also still about the health worker and just having the right skills mix, not just having the clinical expertise, but do they have patient what we call customer care in the corporate world, but are they able to handle women in a kind way, in a more empathetic way, regardless of their situation, regardless of their economic background or their education background? So, or even where they're coming from, maybe they're coming from a different culture than them, and that it has placed them in a particular situation, like what I've mentioned about female genital mutilation. So those are some of the issues. There is also the whole issue about the community being empowered to demand for quality services, to know that they should be respected, they should be offered dignified care. So there is that gap. How do we ensure that communities are able to hold duty bearers to account, so that they're able to have dignified care during this time of delivery and post-delivery? Yeah.
Thank you, Anne, and very clear barriers, and really good point about. I like what you're saying about that customer care. I think we can all relate to that. So, with that in mind, can you tell us a little bit how Amref is designing programs to include RMC into them and ensuring that care, that customer care, that client care, that patient care, as it were, and that women are treated with respect and with dignity?
Yeah. I'll start by saying that we do have a strategy, an organizational strategy that is from 2023 to 2030, with every 3 years of looking at our progress and changing what's not working and scaling what's working. And in that strategy, a key component is on quality. So as we look at our programs, as we design new programs, and as we look at the programs we have to ensure that we entrench quality in it. How do we ensure that health workers have the right skills mix, not just the clinical skills, but also the soft skills? How do we engage our leadership to ensure that they're investing in the right infrastructure, in newborn units, in maternity theaters? So a whole range of interventions under that pillar. But when we come closer home in terms of designing programs, when we design a new program, we ensure that women's voices are part of it. So we co-design with women. Adolescent girls are part of it, so that they can define what do they view in their culture as respectful maternity care, so that their voices are part of this. Then secondly, as we implement, we ensure that we are using rights-based approach. It is not a favor to offer women quality services, including their experience in health facilities. Are their preferences considered? So we use right-based approaches when we do our programs. The third thing is empowering communities under a broad area we call social accountability, ensuring that other grassroots organizations are able to understand how do you hold duty bearers to account in a very systematic way. If you go to a low-level facility in Kenya, and in even most African countries, you'll find what we call the service charter. They say that waiting time is this. This is what is expected of this facility. But how then? How do you empower these communities to be able, when they go to that facility, they're able to have that dialogue, that this is what the expectation is, but it doesn't meet what is being delivered to either a partner or someone in the community when it comes to childbearing. Then another thing that we do is to really contextualize our programs. For example, we work in a county known as Turkana. It is in the northern arid lands. Has quite very poor indicators when it comes to with education. The poverty levels are high, maternal mortality has been high, but we have progressively worked with other stakeholders to ensure that it's decreasing. And we ensure that programs are recognizing the culture of that community. For example, when we had conversations with communities there, they said very well, we don't deliver children on delivery beds, on the couches. So, and what is the alternative? Women in that community deliver while squatting. So what we have gone ahead to do with other stakeholders, including UNICEF, the government there, is to design what we call the birth cushions. So they're like seats, and women, that's what is placed in those facilities. Women are comfortable to come to that facility to deliver, and they don't shy off. So just ensuring that our programs are also contextualized and they are cognizant of the various cultural differences depending on where our program is. Yeah, those are some of the things that I would mention, but more so using a human-centered design, where you are ensuring that you're responding to the needs, the preferences of women and their communities. Yeah.
Brilliant. So very sort of that women-centric focus, hearing their voice, working with people at different levels, really, really interesting. I was just wondering, and whether there are any innovations you want to share that the program is currently working on in integrating RMC, anything you want to sort of highlight, and then I'll come over to you, Brenda.
Yeah, there are several, but what I'd love to share, because our time is limited, is what we have realized as we work on towards just improving our maternal and newborn health indicators, and how can we use AI, artificial intelligence, to really support health workers who work in the maternity and who work in newborn units. Because what we've realized is that as much as there is that which can't be condoned, that, abuse of women, but there's that which is about their own, the system. How do we organize services better? How do we give cues to health workers to model the right behavior? So what we are currently doing is we are testing it out into high-level facilities that have many deliveries in Kenya. So we want to build that prototype. How do we support the health worker in terms of ensuring that workflows are better, they're more efficient, and that their cues to behavior, whether it is on infection prevention, that there is something to give a cue that you need to have washed your hands before you handled that neonate, or there's something you missed, or it is time to switch from this particular machine to use this one, let's say it's in resuscitation. So that's what we are currently working on, and I would be happy as we move along to share others, even from Zambia, and on what we are doing in terms of RMC. Yeah.
Great, thank you, Anne. Yeah, so it'd be great at some point, and maybe Brenda, you can bring that out about how we are training health workers in RMC. How do we ensure that respect, that dignity, and so on. So turning to you, Brenda, in Zambia, can you tell us a little bit what the situation is like there? But also, I understand there's just been a state of emergency declared because of the drought. So how is that? That must be making things even worse, no? You're on mute, Brenda. So Brenda, you're on mute. So I think you should be able to unmute yourself. Go right down your screen to the left. Yes, now.
Okay, thank you. Thank you very much. Thank you very much. Just as my colleague Annie from Kenya said, issues of disrespect and abuse are real, even from Zambia. So, as you have already alluded to, there was an issue of cholera, and also there's an issue of the Zambia as being put on an emergency whatever from the president. Yes. So for cholera, first let me speak to cholera. For cholera, most of our midwives, because in Zambia we started training. When we train nurses, we train as midwives as well. So the same people who are nurses and midwives was supposed to attend to our women and newborn. So when there was an outbreak of cholera, some of our nurse midwives officers were also taken to take care of cholera patients, meaning that the women that are coming to deliver to our health facilities, the women that are coming for antenatal care, the women that are coming for postnatal care, are in short of staff to attend to them because most of their staff have gone to attend to the cholera patients. So meaning that even as we speak for at the respective maternity care, because the healthcare providers are not many, healthcare, healthcare providers are not sufficient, meaning that much as they want to be around, much as they want to be available for our mothers that are coming to give birth, our mothers that are coming for antenatal, our mothers that are coming for postnatal, they don't have enough staff. So this means that we are not observing respective maternity care because of lack of staff. Yes. And the other thing is that the resources from the government of Zambia, much as they want to put a lot of resources to go and attend to the women that are coming to deliver, the women that are coming for antenatal care, the women that are coming for postnatal care. The resources, because cholera also was another emergence for Zambia. The resources were directed towards our pregnant mothers and also postnatal mothers had to suffer because of the cholera outbreak. Now, I want to also speak to the drought, which was declared as the national disaster by our president. This is something which is very sad, not only for the Ministry of Health, not only for the partners such as Amref, but for everyone that looks at health. And for us as Amref that are looking at maternal health, this is very sad because we know that much as we are fighting maternal days, we are fighting very hard for the maternal days to come down. This is something which is going to be very difficult because one, there's going to be poverty in the country, much as we are already experiencing high levels of poverty with the drought thing. The poverty levels are going to be high. A mother with their partner, probably a family that wants to take a woman to go for antenatal, to go for labor and delivery, to go for postnatal services, probably is far away from their home. When they think of transport to go to the facility, and then they think of the cost of buying a bag of mini meal. Mini meal is the meal that we used to buy to do our staple food. Probably they are going to prioritize mini meal because there's hunger in the country, meaning that that woman who's supposed to go for labor and delivery will be home, and in such we're going to end up with a maternal death, probably maternal and neonatal death. Yes. Then the other thing is probably people have got enough money for transport, but during pregnancy they're going to be starved. They're going to have anemia, they're going to have malnutrition. What do we expect from this woman who's going to give birth? Probably the baby is going to come out okay. But what about this maternal, this mother who has been carrying a pregnancy without enough food? They're going to find themselves very sick, even when they have postpartum, bleeding after birth. Because the blood wasn't sufficient during pregnancy, they're going to die due to bleeding. I don't want to go into all those details, but I want to also to speak to something else. Yes. When they go to the clinics, hospitals, whether it's primary health care, whether it's a hospital, second or third level care of healthcare, yeah. Um, there's some stuff with these women are supposed to go with as they are going to deliver. They need some baby stuff. They need maternal stuff which they are going to use as they deliver in the hospital. And when they are pregnant, now that we are in a state of emergency, yeah, now that we're in a national disaster, they prioritize buying food for the siblings, for the children that are home, than buying those stuff that they're supposed to carry with when they go to the hospital. And sometimes when they go with things that are not like in line with what healthcare providers expect when those women come. Those women will opt to deliver from home because they're scared of being disrespected at the health facility. Because when they don't have the things that the baby needs to use immediately after they are born, the things such as maternal, okay, like sanitary pads for the mother when they deliver, the wrapper, in Zambia we call it a chitenge, a wrapper which a mother is going to use when they deliver. They go without all those things. Probably our healthcare providers will look at them as the lower class people, and every woman doesn't want to be viewed that way. So this will cause these women not to go to the hospitals. So this national disaster for me as a midwife, I feel very sad because it's going to cause a lot of probably maternal deaths and also neonatal deaths. Yeah, that's what I can say for now. Thank you.
Thank you, Brenda. And it does make things so much more difficult for you in at so many levels, yeah? Both in terms of the level of need being so much more because of the cholera outbreak, but also in terms of the whole access to food as well as health. Can you just say how you're trying to? I mean, I know the project is called Closing the Gap, and despite these really difficult circumstances of an outbreak, a cholera outbreak, of drought, despite this, you are trying to close that gap. Can you say a little bit about how you're doing, what you're doing exactly, how you're closing that gap, and especially around the
Yeah, thank you
training
very
for health workers? And you talked about the kits and the importance of dress and having the right, I'm not going to try and pronounce it, but the wrap for the baby. Those things are all so important. They are about respect, they're about dignity. How is Amref in Zambia and through this particular project dealing with that?
Thank you very much. Thank you very much. And I'm really grateful for giving me this platform. So, first and foremost, Amref Zambia from 2017 to date, we embarked on closing the gap between the communities. Communities, when I say communities, I mean up to the end user, closing the gap between the communities and the formal health sector. So what we've been doing is we've been orienting the community health workers. I mean, the community health workers. The community health workers are the key between the health sector and the end users, the recipients of care. So we orient them in terms of the rights of these women and in the women and their families. We orient them to tell them what is expected of them. We tell them about the dignity that they're supposed to enjoy where was there at the health facilities. Much as these women know that they're supposed to go with a minimum package as they go to deliver at the health facilities, we tell the community health workers to orient these mothers and their families to say that regardless of what they have, they need to come to the health facilities. Because much as we can dwell on what these people need for the baby like for what mothers need, we need to save these lives. We need to save the life of a mother. We need to save the life of the newborn, the unborn baby. So we have embarked on this journey since 2017 to orient the communities who have also taken this message to the communities so that the communities, even if they don't have anything, they come to the health facilities in order to be delivered. In case they're disrespected and abused during the course of the childbirth or during the course of antenatal, during the course of postnatal, we have developed a mechanism of these people reporting so that when they report to the in charge for that particular health facility, we are able to send this message to the Ministry of Health headquarters so that they're able to address that. And some of the times, the government issues, political issues, sometimes the government will tell you that we have everything that we may need to come and deliver. Worse is nothing, because they want to have a point as well, of course. So what we do is, even if somebody doesn't have anything, we teach the community health volunteers or community health workers to go and teach these people in the community so that they can come to the health facilities. And let me just mention that from 2017 to 2021, we had a bit of funding from Amref Netherlands. I don't know where they got the funding, of course, from Well Wishes, where we wanted to see if this whole thing can work. Yeah, so we implemented this on the Copperbelt province of Zambia, and we implemented at Kitwe and Dola. Kitwe and Dola are two big cities of the Copperbelt province, and those two big cities are like 50% of that province, to see if it was not going to impact, or if it was going to impact on maternal health. And we trained the policymakers, we trained the community health volunteers, we trained the care providers in respective maternity care. What did we see? We saw that no one, in the time that we're implementing that project, no one delivered from home. They all went to deliver from the health facility, because they were taught that people at the health facility know that they are supposed to respect you. What else did we see? We saw that there was no one dying in the community. Of course, I'm not going to say that no one in those communities died. Probably there are a few people that started off all late to go to the primary health care facility. They saw that there was a complication. They took them to the third level hospitals, and probably they died. But that was a minimal number. I don't want to talk about statistics now, but we saw that we scored in that area. And we were able to do also an inline evaluation, where we saw that people thought that when people are respected, they recommend health facilities to their colleagues in the community. When people are respected, we saw an increase in the institutional deliveries. We saw an increase in the skilled deliveries. We saw a decrease in neonatal deaths. We saw a decrease also in maternal deaths. So for this one, I would say that as Amref Zambia, we're trying everything possible. And just to mention, by the way, after that project came to an end with recommendations from the government of Zambia and the Nursing and Midwifery Council of Zambia, they recommended that this soft skill, the respective maternal care, needed to go to the whole country. We were given Amref headquarters, and we started also orienting and training the Nursing and Midwifery Council of Zambia. As I'm speaking, we have the guidelines for the respective maternity care, which the people in delivery centers are using. We also have respective maternity care embedded in the midwifery curriculum. This was a recommendation from the project that we embarked on up to 2022. But what I'm trying to say now is that much as we have done that, we need everyone that is attending to women pregnant, delivering, and postnatal to have this information. So what the resources that we need are to train everyone who are attending to these women. When I say skilled at birth attendants, we mean midwives, the doctors, medical associates, nurses who are working in the areas who are supposed to attend to these women who are giving birth, who need that skill, because what they need is to attend these women nicely. If they have want to refer these women in good time, when they refer these women in good time, we're going to have less deaths or in maternals, and we're going to have less deaths in neonates. Yeah, I think
Thank
for
you.
now, let me leave it here.
Thank,
Yeah, Camila, thank
thank you.
you.
Yeah, thank you so much, Brenda. That was such good examples of the impact that you're having in terms of people actually attending hospitals and health facilities, and the word, the importance of sensitizing at all levels, right? Among the community, word of mouth going out there, and how important that respect is in order to ensure that. That's so helpful. Also, I hear you around embedding it in the curriculum for health workers, again at all levels, whether you're a doctor, midwife, and so on. So that respect, that dignity. Thank you. That's really great. Brenda, I think what would be fabulous now, and I'm going to ask the team to just show that little video of Hope Tabitha, who's actually talking about her experience, and we'll put that on now. And Brenda, you've worked with Hope, I believe.
Yeah, yeah. That's from my work area.
About my children, they are my pride. I love them. When I look at them, they give me courage. Yes, they give me courage, and I would really want them to reach heights. So everything that I do it for them. we like have a good time with them. Yes. That's how I said, like, having clothes heavily. Yes, heavily bleeding. That's when I was taken to the hospital. Either of us, any one of us would have died because the bleeding was too much. So it was like an emergency case. You can't bend, you can't do anything. At times you'd even fail to breastfeed the baby because of the severe headaches that comes after the whole process. Losing a companion is not an easy thing, yes. It's very much hard. You were in love before, then your joy just goes away like that from the blues. Yeah. It's difficult to raise the children alone, and the worst part was that I was left pregnant. So seeing the pregnancy, carrying the pregnancy without him, and putting to bed without him, it hasn't been easy. But Aunt Josephine was always encouraging me because she even knew about my husband's death, so she was always by my side. She would encourage me, no, don't worry, this child is a blessing. She used to like take care of me so very much when I was pregnant. Took me for the first appointment, and she was always there for me. So she would always pass by to emphasize me if I've already taken those important medications.
Brilliant. Thank you. I think that illustrates well what we've been doing and the support that Amref's been giving, not just at birth, but also after birth, linking this particular Hope, this particular person with a community health worker, and that ensuring that continuous care at a very difficult time. I'm just aware of time, and I was just thinking it would be great to be able to have some of the audience questions. So in the interest of time, Brenda and Anne, if you could stay on standby, I'm going to turn to the audience because I can see there's already a number of questions there. Can someone bring them? Here we go. So, does Kenya have any programs offering reversal amelioration of FGM? This is, as a midwife in the East End of London, I saw how popular this is when offered to women antenatally. Question. That's one question. Brenda or Anne? Maybe Anne, given that it's Kenya. So reversal of FGM or amelioration.
Yeah,
SGM.
okay.
Sorry, just because it's Kenya, Brenda, the question is directed to, I thought, Anne, it would make sense for Anne to respond. Thank you.
Yeah, thank you for the question. Yes, there is, but it's privately offered. So it's not accessible to majority of the girls or women who would want that service. We are yet to have a framework in terms of how that goes about in the public sector, but there has been various conversations, but mostly on the issue of medicalization of FGM, but not on the reversal yet in terms of the public sector. But the services are there in private health facilities. Yeah.
Brilliant. And I'm going to go straight to the next question, which is for both of you. But if we just start with you, Anne, again, and then pass on to Brenda. This is from Pius, who's asking, who's based in the US. What support is Amref receiving from, Anne, in your case, the government of Kenya, to boost Amref services?
I would say a lot because Kenya is now a devolved state. It's been for the last 10 or so years. And we have seen a lot of investment go towards health, the health sector, improving access. In some areas, we still do have, communities in last mile, communities in far-flung areas where they don't have facilities, but it has done a lot in terms of improving access. There before, Amref used to work on models, outreach models, where we would use planes to go and deliver services to particular groups of people. But some of these communities now have a health facility. They have a health workers, even if not adequate, there is at least one health worker in that facility. And what we continue to do as Amref is to engage government. Where can they, invest further? Where can they invest in terms of more strategic purchasing so that we save more women's lives, more children's lives? So I would say yes, but it's still not, to the level where we have been able to see very significant changes, especially in our maternal mortality ratio or neonatal mortality ratio, but there has been those investments.
Thank you, Anne. And Brenda, from the government of Zambia, how involved are they? How supportive are they? Brenda, are you there? You're on mute and I can't see you. Brenda? Okay, maybe we'll come back to you, Brenda, about the government of Zambia and its support or not of Amref services. Because there's many more questions. So so the next one is from Charlotte. I wonder if your programs, particularly with the young women you work with, ever include young men and boys too. Would it be right to assume that the better informed the men folk are, more likely women are to be supported when they access healthcare? And she obviously, Charlotte, there references our FGM work, where we do a lot of work with the boy child and men as well. So Anne, do you want to say something about that? What are we doing with boys and men?
Yeah, maybe I can share a little bit about that. We do have programs that are in sexual reproductive health and rights, where we target young people, boys and girls. And actually, just to mention, we work very closely with the Amref UK office, where we use sports to reach vulnerable young people who live in informal settlements to ensure that they have access to information and link them with services on adolescent health. Just to go further into your question regarding how do we engage men or boys, first of all, we look at them as as individuals who need services, because SRH, child reproductive health, there are many other services that men or boys can get from that, testing for HIV, linkage to treatment, and that kind of thing, but also men and boys as partners. And when our country is largely patriarchal, so we have to ensure that we are doing the right engagement, we are involving men at all the levels, including boys, in terms of how do you have models that look at behavior formation, so that later on you're not investing too heavily on behavior change. How do they instill positive masculinities among young boys? But also we look at it as a dual approach. While we work with men, we have to also look at girls and women and their autonomy. How do you empower young girls and women to be able to own their own, to know that health is their right, that it cannot be taken away? Of course, you have all these barriers, but it is their right. And some of the things that we are looking at, especially in the area of family planning, is how do we promote self-care, like use of the subcutaneous DMPA. It is an injectable where a woman is able, you do not have to go to a provider or keep discussing with so many people, but you are able to have that power to be able to get the service that you need. So it's a dual approach, but we are very cognizant of this whole fact that our communities are largely patriarchal. Yes.
Thank you, Anne. Thank you. And we've got Brenda back. Just a couple of questions, Brenda. I don't know if you caught them. One is, to what extent is the Zambia government sort of supporting Amref?
Yes, please.
And then the second question is,
Yes,
to
please.
what extent are we working with boys and men in our maternity health care work?
Okay, I've gotten the second question, but I haven't gotten the first question. So let me respond to the first question. So the first question: how are we working with the boys and the girls? So with the boys, nothing much, but with the men, because whenever we're educating the community health workers, we want the men also to be workers about the danger signs that need them to rush to the hospital when there are women experiencing. The community health workers that we're working with, that when the men go in the community to educate their fellow men, is going to yield results. So for the boys, we are yet, of course, we have got adolescents. When we're talking about adolescents, when you teach them about sexualities, what have you, we make a program for males, yeah, for the boys, yeah. Then the first question, probably Camilla, you can take me through to the first question.
The other question was around to what extent the government of Zambia is supportive of the work that we do in Zambia. How much is it involved? How do we work with the government in Zambia?
Okay, thank you very much, Camilla. So for that question, so the government of Zambia, so in this case, I'm speaking in the context that we're here with. Okay, let me put the camera on. So
Don't worry
the
about the
government
camera
of,
because we can hear you well. Don't worry about the
okay,
camera.
okay.
From the point we can hear you.
Okay.
Yeah.
Okay, that's fine. So for the government of Zambia, in the strategic plan for 2024 to 2030 that put respective maternity care as a priority. Of course, we started as Amref, we started respective maternity care in 2017, but now the government has put respective maternity care as a priority for this strategic plan, meaning that they are committed to ensure that skilled birth attendants have got knowledge in respective maternity care. Another thing is as Zambia, we have every week, we have 2 meetings in a week, which happens virtually to discuss maternal and neonatal days from all the 10 provinces of Zambia. We have a triple analysis just to see this death which occurred, is this to do with the family? Is it to do with healthcare providers? Is it to do with the unskilled people that attended to this mother? So meaning that the government of Zambia, the Ministry of Health of Zambia is committed to see that there's a reduction in maternal and neonatal mortality in Zambia. Of course, Camilla and everyone else on this call know that Zambia is a developing nation. Probably even as we allocate resources, the resources, that financial resources, it's not much. Like when we want to train people in this respective maternity care, want to train community members to alert people in the community to go and seek health services in the community, at the health facilities. We don't have enough resources as the country. So even respective maternity care, even as it is in the strategic plan, the Ministry of Health is looking up to partners like Amref and other partners in Zambia that are working on their respective maternity care space to see if they can fund some activities relating to respective maternity care, because we know that this is a soft skill that can save a life of a mother and a neonate. I don't know if I've answered everything for now.
Yeah, it's super clear. Thank you, Brenda, and really encouraging that it's such a priority for the government of Zambia as well, and that it's part of their strategic plan. Wow. So I'm just aware of time. We've literally just got a few minutes left, so I'm gonna try and combine some questions here. To what extent is Amref working with the professional associations, midwifery and obstetricians, as well as Amref University? And then there's one last question, but if you could answer that. So to what extent are we working with these professional associations or even Amref University? And do you want to?
Okay, I can speak to that. So for Zambia,
okay, Brenda, you go first. Yeah,
for Zambia, for the local universities, we have quite a number of universities that are training nurses. As I'm speaking, we have one project, we call it Learning for Life. Learning for Life in the sense that as the healthcare providers, they need to learn, and learn no more. And so we have this project that is focusing on upgrading healthcare providers, in particular the nurses, those with a lower qualification, to upgrade them to registered nurses. Registered nurses, at least even if they are not midwives, we know that they're able to save a life of a mother and a newborn. So with the Amref University, much as I would want to say that we haven't worked much with them, but whatever courses that they have for maternal and newborn health, they have shared with us, and we have shared with our partners in Zambia. And these partners, probably, I don't want to give you a number. We have quite a number of Zambians that have enrolled with Amref University. And we have also, from Amref headquarters, most of the courses, especially for the ones that are progressing to registered nursing, they are the ones that are managing the platform for e-learning for these people that are upgrading, because e-learning is good, because within a year they're able to upgrade to a next category, which is approved by the Ministry of Health to save mothers and newborns. I don't know whether I've answered you adequately.
Yeah, no, thank you, Brenda. What about in Kenya, Anne?
Yes, we do work with the professional associations. We work with the Nursing Council, the Kenya Obstetrics Gynecological Society, Neonatal Society of Kenya, and many others. The first example I'd give is about capacity building, where we have had discussions with these professional associations, and they learn from our digital platform in service so that they are upgrading their skills and also earn points that go towards their career progression. So that is the one way that we work with them. The second issue is that we build their capacity to be able to, build professionalism, to be able also to hear them out about their rights. There are many issues about health workers. Maybe they do not have, the right supplies as much as we are demanding of them to provide, respect for maternity care. Maybe there are no gloves, there are no other commodities. So how do we, just instilling in them those skills on engaging the right authorities. Then the third one is we co-create programs with them where it comes, where especially we are looking at a particular cadre. If you are working on newborn health, we work a lot with the Neonatal Society of Kenya because these are experts and they share what they see in the facilities, and they're part of modeling what will eventually roll out on the ground. Yeah.
Right. Okay. So we've already overrun by 1 minute, but Sarah, I'm aware we haven't answered yours, and there's one more question. I'm just going to ask for Sarah, who came before the last one. Can you just quickly say about the situation around water, and maybe starting with you as you were speaking now, what kind of water facilities are there in the health facilities? Is there piped water? What is the situation in terms of access to wash in the health facilities that we work in? So starting with you, Anne, in Kenya.
What our guidelines stipulate is that for you to operate a maternity theater, you have to have water for them, for it to qualify as a maternity. But, we could do better. Many times is maybe the water, the taps run dry, or we don't have a reliable source, or they're relying on electricity, the one from the grid, and it's not very reliable. We could do better with maybe use of like solar, especially in counties where we have a lot of solar energy. So we can improve to make women's experience better. But at a basic minimum, these things do exist for you to run a maternity or a newborn unit. But usually they are in maybe too few or in dilapidated conditions. Yeah.
Mm-hmm. Thank you, Anne. And just very briefly, Brenda, what's the water situation, water access to water facilities, pipe water in Zambia? And then we're going to close with a little video. Brenda?
Yeah, thank you very much, Camilla. So for water situation, or should I say wash situation in Zambia, for the maternity wings or for the health facilities that are in urban facilities, those amenities are available. But when you go to the rural Zambia, you find that this is a rural health center, which is like a delivery center, but you find that there's no water because there's no running water, meaning that even the placenta, when someone delivers, they're expected to carry to their home to go and bury, because at that health facility they don't have the amenities like maybe even the incinerator. Anyway, I've diverted a bit. They're going to carry the placenta to go and bury. And in terms of water, somebody who was delivered, they went back from their homes because where they're delivering from, there's no water at all. So this is a common problem in the rural health centers. In towns, a bit okay, but it's like 50% of urban facilities, people have got access to water where they can bath before they're even delivered. 50%, there's nothing. But for the rural facilities, almost all the facilities, there's no water where this mother that has come to the river can bath. Thank you.
Thank you, Brenda. And we've run out of time, I'm afraid. It's been really, really interesting, and we still have some questions, but we will send the recording out and attempt to answer those questions as we send the recording. A huge thank you, Brenda and Anne, for your participation, for all the work that you're doing, both in Kenya and in Zambia. Really impressive. We're going to end with a little video, which Izzy will be showing. And UK supporters, you'll be hearing more from us on this theme over the next few weeks.
Watotera sana pakutusambirisha ukupusisha myosha abana mayo n'abana muno mu Zambia. Twatotera, thank you.